Yes, sir, please proceed.
Yeah, thank you. So, welcome all the delegates for joining me in this evening session, and I'm going to talk about pioglitazone, the adverse events and the myths and the facts related with this particular molecule. In the previous session, Dr. Deka has already talked about this, agent very well, but I'm going to take a little bit, in-depth message regarding the pioglitazone. So we'll have four sections in the talk. The section one will be a little bit overview regarding the pioglitazone as a molecule. In section two, we'll go into the depth of the myth versus facts. In section three, we will look at whether pioglitazone is able to outweigh the benefits, is able to outweigh the risk. And in section four, we'll talk about the key take home messages. So, as an overview of this agent called pioglitazone, what we know about it is that pioglitazone is an extremely potent insulin sensitizer. There is a preservation of the beta cell function and it works independent of the beta cell function. And there is a very, not only durable, but a very significant reduction in HbA1c. It corrects multiple components of the metabolic syndrome. And there is also improvement in NFLD and NASH. So this is just an overview of the molecule. So insulin resistance in muscle and liver is at one of the more core physiologic defects of type 2 diabetes. Now we know pioglitazone works through the PPR gamma activation at the nuclear level. So sometimes there is a little bit lag in the effect that the pioglitazone starts showing in our patients. So we need to be a little bit patient while dealing with this agent because it's working through the nuclear receptors. And it improves the insulin sensitivity via multiple mechanisms, and that is through the stimulation of the insulin signal transduction. It improves the glucose transport, glycogen synthesis, and glucose oxidation. It also works at the level of the mitochondria and improves the overall mitochondrial function. It also reduces the plasma free fatty acid levels and thereby reversing the lipotoxicity that happens in our diabetic patient. Now, as I was talking about, that pioglitazone 15 milligram per day can reduce the HbA1c in around 0.92%, whereas pioglitazone 30 milligram per day can reduce by more than 1% HbA1c. And this reduction is also not only significant, but this is durable in the course of time. Now, if we go into the section two of our talk, that is the myth versus the facts. Now, in the myth versus fact one related to weight gain. So the myth is that pioglitazone causes weight gain. Now the fact is that pioglitazone actually does cause some fat weight gain, but there is also a lot more in depth regarding this. So we know pioglitazone increases body weight by stimulating the PPR gamma receptors in the hypothalamus to augment appetite. And then pioglitazone simultaneously stimulates the PPR gamma receptors in the subcutaneous adipocytes to induce genes involved in adipogenesis. So there's adipogenesis at the level of the subcutaneous adipocytes. And these newly formed small fat cells take up the free fatty acid that is, running in the plasma, thereby reducing the plasma free fatty acid concentration. And the decreased flush of this free fatty acid into the liver will happen because this small adipocytes or newly formed fat cells are taking up the flush of the PPA and thereby preventing them going into the liver, muscle, and the visceral fat depot. So there is a kind of a fat redistribution that is happening in patients where we are using pioglitazone. There's some additional mechanisms like it stimulates the PPR gamma co-activator 1, causes transcriptions of mitochondrial genes involved in the fatty acid oxidation. So not only is taking up the free fatty acid flask from the plasma, but it also increases the intracellular and hepatocyte lipid content. It reduces by inducing the fatty acid oxidation at the level of the mitochondria and thereby reducing the lipotoxicity. Now, weight gain is common with pioglitazone therapy, which is typically amounts to 2 to 3 kg of fat mass over a 1 year period and is mostly dose related. So if you're using the lower dose, you can expect a little bit of lesser weight gain. If you're using on the higher side, then you will expect a little bit higher weight gain. However, the greater the weight gain, the greater is the decline in the HbA1c and the greater improvement in insulin secretion and insulin sensitivity. Now, weight gain was associated with actually increased survival in the proactive study and mobilization mobilizes the fat out of the arterial wall. So this is again very important because this makes it anti-atherogenic. So no specific adverse effect of the fat weight gain has actually been observed in type 2 diabetic patients treated with pioglitazone for even up to 3 to 6 years. Now, advices what we can talk about regarding weight gain is a dose related and can be minimized by not exceeding a dose of more than 30 milligram per day. And by this point, we expect 80 to 90% of the drug's clinical glucose lowering efficacy. Now, combination therapy of pioglitazone with metformin minimizes this weight gain. And if you're using it in a combination therapy with SGLT2 inhibitor specifically or GLP-1 receptor agonist, it reduces both weight gain and the fluid retention. So such combinations can also take care of the little problems that might arise out of it. In myth versus fact 2 related to edema and heart failure. So the myth is that pioglitazone causes edema and heart failure in all patients. But in fact, the fact is that pioglitazone may increase the risk of edema and heart failure in patients who are at a high risk or already in heart failure. So how pioglitazone causes edema and heart failure? What is the pathophysiology behind it? So the main effect is on the vasculature to decrease vascular tone. And then there is a secondary sodium retention because of the vasodilation leading to an edema. Now, the fluid accumulation happens in a non-compliant ventricle sometimes, and that might lead to a heart failure. However, in the IRIS study, what we find is that the number of patients who developed heart failure was very similar in the pioglitazone-treated and the placebo-treated groups. So per se, pioglitazone causing heart failure is not that well established until and unless the patient is already at a high risk of heart failure or already having heart failure. So probably in those situations, it's better to avoid the agent. The study also did allow for a dose reduction for edema or weight gain, not responding to initial lifestyle recommendation. And probably we can also follow this if a patient is complaining of edema or weight gain. Now, pioglitazone treatment is associated with edema and appears to be dose related. Again, very important. So if the patient is developing some kind of edema, you might try reducing the dose. So when pioglitazone is used in combination with sulfonylurea or insulin, the incidence of edema is increased further. So we should be a little bit cautious in such situation. It is not that it needs to be avoided completely, that you cannot use pioglitazone with sulfonylurea or insulin, but you need to be a little bit more careful in such situation. If more than trace edema is present, treatment with one of the distally acting diuretics should be instituted and the dose of the pioglitazone reduced. And in today's time, we have with us agents like SGLT2 inhibitor. So if we are combining them, then it can also take care of the edema to a certain extent. Myth versus fact 3 related to hypoglycemia. Now, patient's myth is that the patient receiving pioglitazone may be at risk for hypoglycemia. The fact is that pioglitazone is associated with a low risk of hypoglycemia. Now, if you look at the clinical evidence regarding hypoglycemia related to pioglitazone, in the first study, we have shown you an observational study from the UK, where the incidence rate of hypoglycemia was 50 to 100% less in pioglitazone-treated patients, as opposed to those who were on nataclynide or ripactinide. In study 2, pioglitazone monotherapy was associated with much less hypoglycemia than glyburide-treated patients with newly diagnosed type 2 diabetes, and this was statistically significant. In study 3, pioglitazone-treated patient had significantly less hypoglycemia when used as an add-on therapy to sulfonylurea or metformin as compared to insulin glargine. So from this data, we can understand this pioglitazone per se doesn't cause that much hypoglycemia. It is a very low hypoglycemic risk. But if you're combining this agent with sulfonylurea or insulin, then obviously those patients might be at a higher risk, not because of pioglitazone, because of the other agents. Now, in combination with insulin, the rates of hypoglycemia are higher than in insulin use alone. So sometimes we need to reduce the insulin dose when the patient is also being prescribed pioglitazone. We need to be a little careful in such situation. Reduction in the dose of concomitant agent might be necessary. So either reduction in the pioglitazone dose or reduction in the insulin dose is something that we need to consider. In myth versus fact 4 is related to bone fracture. Now, pioglitazone, the myth is that pioglitazone may increase the risk of bone fracture in all patients. The fact is that pioglitazone may increase the risk of bone fracture in individuals at high fracture risk. So that includes a postmenopausal woman with established osteoporosis or those with prior fractures with low trauma. So low trauma fracture is actually indicative of osteoporosis, and postmenopausal women with established osteoporosis are the areas where you need to be a little careful before using pioglitazone. So if you look at the clinical evidence regarding bone fractures related to pioglitazone from the Tosca study, what was seen was pioglitazone was compared with active sulfonylurea therapy in more than 3,000 participants with type 2 diabetes for as long as 57.3 months, and no significant increases were noted in fractures in pioglitazone exposed either female or male participants. And myth versus fact 5 is related to bladder cancer, and this has caused a very high uproar, maybe around 10 years back. And the myth is that there is an increased risk of bladder cancer with pioglitazone, and it is very well established. The fact is that although the increased risk of bladder cancer with pioglitazone is not well established, pioglitazone should not be used in type 2 diabetes with an active bladder cancer or a history of bladder cancer. And that is also, because we don't have enough data, right? So because there is some suspicion, okay, so we don't want to use it in a patient with active bladder cancer or with established history of a bladder cancer. But otherwise, pioglitazone causing bladder cancer is absolutely not well established. Rather, the reverse is true. So there was some proposed mechanism that how can pioglitazone cause bladder cancer. So there was some theory given regarding the crystal formation or the bladder irritation hypothesis, and this were believed to be the possible mechanical effect that might cause it. But no pharmacologic effect actually appears to happen through the PPR gamma pathway, where there is through which actually the pioglitazone works. So if you look at the evidences regarding this, so what we see is in the number one, we have a midpoint analysis of 10-year study, and it failed to find any association between pioglitazone and bladder cancer with sensitivity analysis showing that the neutral effect was present irrespective of the dose and the duration of therapy. In the multinational cohort study, the hazard ratio for bladder cancer with pioglitazone and rosiglitazone was absolutely at the unity, and the p-value is non-significant. In the IRIS study, there was no increase in bladder cancer was observed in the pioglitazone group versus the placebo. Now, in the myth versus fact 6, that is related to anemia. Now, the myth is that pioglitazone causes anemia throughout the duration of therapy. The fact is that pioglitazone decreases some degree of hemoglobin in around 2 to 4%, very minimal, and without clinical consequence only within the first 4 to 12 weeks of therapy. After that, it plateaus off. Now, how does pioglitazone cause this anemia? So pioglitazone causes a little bit of bone marrow suppression and has a dilutional effect due to an increase in the plasma volume. If we look at the data from the clinical studies, what we find is that mean hemoglobin values decreased by around 2 to 4% in patients treated with pioglitazone, and anemia usually occurred within the first 4 to 12 weeks of therapy and remained relatively constant thereafter. So rarely been associated with any significant hematological clinical effects. Okay, so these are mostly theoretical issues. Clinically, we don't see much of a problem. Myth versus fact 7 related to liver damage. The myth is that pioglitazone is associated with severe liver damage. The fact is that pioglitazone is associated with metabolic and histologic improvements in diabetic patients with NASH. Now, if you look at how there's glitazones with multiple actions preventing or treating or preventing NASH. So pioglitazone, it improves the histological features, reduces the hepatic steatosis, reduces inflammation and ballooning without worsening of the fibrosis. It improves the insulin sensitivity, as we talked, in the liver, skeletal muscles, and adipose tissue, and thereby helping us to resolve NASH. So one of the very important agents that we use in our patients who have type 2 diabetes along with NASH, and should be at the front if there is no strict contraindications to it. Now, if you look at the risk-benefit ratio of pioglitazone. So just to highlight that it might prevent around 47 non-fatal MIs and 20 strokes, while it could provoke 2 to 3 bladder cancers for every 10,000 individuals treated over a 3-year period. Has a dubious bladder cancer risk? We don't know for sure, but most of the studies have shown that there is actually not an increased risk of bladder cancer with pioglitazone. Only those who have got active, bladder cancer or a history of bladder cancer, it is a prudent decision to avoid in such situation. And an overwhelming benefit evidence regarding the cardiovascular benefits. Okay, so it's a very anti-atherogenic agent, and the fluid retention that is caused by pioglitazone is not associated with increased mortality, might respond to diuretics, and is most important, is reversible in stopping pioglitazone. It improves the glycemic control in patients with diabetes, and thereby its implication, the microvascular complications of diabetes. So the benefit is much more compared to the risk. So if you look at this, diagram over here, you can see the risk over here, and you can see the benefits on the other side, and the benefits indeed outweighs the risk. So the key message in today's talk is that pioglitazone is a very potent insulin sensitizer, works wonderful in patients with high insulin resistance like Indians, that preserve the beta cell function, works independent of the beta cell function, causes a very significant and a durable reduction in HbA1c, corrects multiple components of the metabolic syndrome, and improves the non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. Pioglitazone has an acceptable safety profile, may have beneficial cardiovascular and pleiotropic effects, and is clinically efficacious in patients with type 2 diabetes. Adverse effects like weight gain, fluid retention, fractures must be considered, it must be kept in mind, but I have told you where you need to keep your attention very, very strict, like patients who has active heart failure, patients who have a diabetic macular edema, patients who are having postmenopausal women with established osteoporosis. Maybe these are the areas where you need to be a little bit more cautious in using pioglitazone. But otherwise, in a vast majority of our patients, it is a very wonderful drug that can take care of multiple issues in our patients. The adverse effects of pioglitazone are clearly outweighed by the multiple benefits that it offers. Thank you for your very patient listening. I'm here if you have any questions for me.
Thank you, Dr. Gaurav. Excellent presentation, very clear in scientific data. We appreciate your presentation very much. One thing you told, 2 patients in 10,000 may get bladder cancer. But previously you have also mentioned there is no evidence of bladder cancer. So
Yes.
What is this? Is it contradicting?
Yes, sir, because so I have taken the worst of the lot. So some of the studies which has, shown that there may be a possible risk of bladder cancer. So even in the most worst, I have compared the worst possible, outcome that may happen, because most of the data today shows that there is no increased risk. But on the safer side, because we don't know exactly what's happening, so we say that if a patient has an active bladder cancer, then don't use. If you have an active past history of bladder cancer, don't use. So even if I take those cases, those studies where it suggests that there might be an increased risk, even that increased risk is like 2 patients per 10,000 patients you treat over a 3-year period. So even in the worst case, you will be preventing around 47 myocardial infarctions and 20 strokes against a 2 bladder cancer that might possibly you might get after 3 years of treatment with pioglitazone.
I think, Alok, this is the literature reviewed, and